Generally, I suggest for you to finish to write them, guys. Listen to me. I use this time, I spend the time, I write these lectures, not to have the writings in my lecture time. Let's have conversation. Anterior wall, surgically important region. And this importance can be divided into two main parts. Part number one, it is in, friends, finish to do anything and listen. Part number one, why it is important, connected with the gates or doors, which I can open from anterior wall into the peritoneal cavity. You don't study peritoneal cavity, but you study anatomy. And you approximately imagine which structures we have behind the anterior wall, yeah? So anterior wall, for myself, can be the door to open the structures inside of the peritoneal cavity. That's it. This is first meaning of this region. I can make here surgical incisions. So I should know very well this region to avoid formation of complications. Here we have big vessels, and if by mistake you can damage it, it can give up to the mortal complication. More of this. You know that any incision, any scar, it is the weak place. And if you will not make properly your incision, you can achieve after post-operating hernias in anterior abdominal wall. That's it. Once again, importance number one for anterior wall, it is huge amount of incisions which we can perform here to open the structures in the peritoneal cavity. Importance number two, connected with its own surgical diseases. You know, anterior wall by itself also can be surgically important, not only due to the open peritoneal cavity, but to treat its own surgical problem. And one of these problems I mentioned 2 minutes before, hernias. So I can make here the surgeries just to improve the situation of anterior wall without any cavity problems. Except the hernias, we can imagine the traumas of anterior wall, bleedings from anterior wall. For example, congenital malformations of anterior wall, defects. For example, we can have diastase of anterior wall. Congenitally, part of the wall is not developed, and we have the fissura, aperture. And for example, open urinary bladder. And I must make plastical reconstruction to close it. I can do it by primary suturing, I can do it by plastical reconstruction, according to situation. Why so long I speak about it? To explain for you importance of the region. That's a point number one, it is important due to performance of incisions and entering into the peritoneal cavity. Importance number two, by its own surgical problems. Is it understandable for you? Brilliant. Now, let's start to speak about the first importance. Then you make incisions to open the peritoneal structures. Yeah? In my previous semester, immediately in the first lesson, we studied the classification of the surgeries. And if you remember, I told you in that time that all surgical accesses can be divided into two big groups. It is so-called local or specific, and general or common. What does it mean, local incision? That's a part of the incisions which I can make in this wall will be locally advanced. For example, you see the local incision, it's shown by blue line. We call it McBurney incision. And this incision is used only for one purpose, to open appendix. That's a local incision, listen definition, guys. Doesn't matter in which part of body you perform. It can be in thorax, it can be in abdomen, it can be in extremities. But local incision, we perform only to open one exact problem. Problem, structure, vessels, pus, but if it is locally advanced, if it can be opened by small access, such kind of incisions we call local. That's another way we can say local incision open one structural unit. So I need to open appendix, I make McBurney. I need to open, for example, gallbladder, I make the Kocher. I make scissor section, I make the Pfannenstein incision. That's it. For uterus, for the Pfannenstein, for gallbladder Kocher, for appendix McBurney. You can see that this is a local form of incision. But now attract your attention in that incision, for example. It is incision along of all wide line. Of course, such kind of incision open not one but 100 structural units. And of course, such kind of incision we call common. So remember, please, definition. Common incision open the big cavities, or completely or by compartments, and give us chance to make the big revisions. Big incisions or common incisions, necessary primary for revision. Then the problem is not local, but it is spreading. And you must find all components of it. For example, cancer with metastases. Pus, which is spreaded through the whole peritoneal cavity, which is called peritonitis. And you will recognize all evidence of this problem. Otherwise, you will have the big surprises in the future. That's again, I tell you, definition of common incision. Common incision open not one but several structures, and common incision used for the diffuse pathological problems, not for local. You study from your pathophysiology or from your pathoanatomy that pathological problems divided into local and diffuse. Let's say if there are local problems, if it is diagnostically investigated problem, we use the local form of incision. If it is diffuse problem, or if it is problem which is non-investigated, we use the common type of the incision. That's a first classification I just introduce you now. Incisions divided into local, into general. Classification number 2, also we studied in previous semester. Surgical access incision can be performed for 2 cases, curative and diagnostical. Say these incisions which I introduced for you and which we will study a little after, I can do for treatment and for diagnosis. Of course, much more usually in open access incisions. I will use for treatment because they are very traumatical. For diagnostical, I will try to use the minimally invasive accesses, which I will introduce later. For example, endoscopical. But anyhow, even open access can be used for the surgery. And in majority of the cases, this diagnostical purpose will be continuous by the treatment. What does it mean? For example, there are extremely emergency situations. I don't have any time even to perform the laparoscopy because just laparoscopy by itself, it is some time needed manipulation. I must make the punctures, I must make peritonization, I must insert the equipment inside of the cavity, but sometimes I cannot have this time. And I will start, for example, with big diagnostical laparotomy, but then we'll come to the treatment. For example, I see that the person loses the consciousness, I see that there are defense, muscular pressure. I don't know what is catastrophe inside. If I will lose the time, patient will be dead. I will make the big laparotomy firstly to identify what is it. For example, I will see bleeding. And second, I will come from diagnostical to curation. I will start to ligate this bleeding or suture. That's why in majority of cases, we don't have strong border between diagnostical and curative. Sometimes they can be used combined. Sometimes they can be used separately. For example, you make access, you come to the peritoneal cavity, the same person which I accept, but there are huge tumors, not investigated. I don't know where is the metastasis. They say, what should I do? I will take the specimen, which is called the biopsy. I will come to outside. I will do my best to investigate this cancer. For example, to make staging of it. Otherwise, the treatment modalities will be ununderstandable. What should I do? Should I make surgery, or maybe chemotherapy, or maybe radiotherapy, or maybe targeted therapy? Because not the surgery only used for the treatment of such problems. That's why once again, remember please, the surgical incisions divided into the curative and into the diagnostical, or sometimes they can be used in combination to each other. Finally, last classification, despite what is it, curative or diagnostical, general or common. It can be divided into the open access and into the minimal invasive access. Open access, it is in front of you. Using the scalpel, we make the incision, we open the big field of the surgery, big or small, comparable to the size of incision. But by our eye view, without optical equipment, we perform the surgical operation. Maximal, we can use some lenses to a little bit make the magnification. What does it mean minimally invasive? With very small apertures, or perforations. We inserted the special micro instruments. We inserted the optical equipment, and we performed the surgery without big access, by small access. Each one has the benefits, advantages, and disadvantages. For example, minimally invasive surgery is great due to the small violation of the structures, due to the short time for the reparation. But it's not so much good from the point of the view of visualization and from the point of the view of the experience. The specialist must be ready to work with the equipment. Otherwise, for example, if I will give you now a laparoscope, you cannot do anything. By your eye control, you can find, for example, in the cavity, for example, some foreign body, touch wood, of course, I will not give you this kind of work, but you can find and remove it. But by endoscope, it will be impossible. You must have trainings. What is the advantages of open incision, open access? Here, great visualization. You see what do you need. You use your hands, not the manipulators. But what is the disadvantage? Violation. Long time for the regeneration. Hospitalization time is long. It is expensive. Idea is understandable. Now let's start from open accesses. Open access or general surgical access. As doesn't matter that now we don't speak about the curative, diagnostical, we just speak about the types and forms. In the slide is written here that all our open accesses, according to direction of the cutting structures, divided into 5 big groups: longitudinal, transverse, oblique, combined, and changing. Name is showing which direction primary you provided this incision. Now let's start from longitudinal incision. By black line, you see, guys, the biggest surgical incision. This is biggest incision, not only in abdomen, forever. Size of this incision near the half of meter. For the adults, for the children, of course, it's smaller. This incision started from your xiphoid process, continues to your pubic symphysis, and as you can see, umbilicus cut it from left side. Not from mid side, not from right side, from left side. Because all my previous class, I teach you why. Now tell me, please, represent it for me. Why umbilicus should be cut strongly by left, not from right and not from mid side?
So because there are vessels, larger vessels in the right side. In the left side, there's like less vessels.
If there are large vessels, name them, please. Why you need to forget the name of the big vessels? If you investigated big vessels here, just tell me, I will study those. If you don't investigate it, why you are so confidently telling me about it? As usually, Frank. Much more better to say something instead to say I don't know. Of course, we have round ligament of the liver with very small paraumbilical veins inside of it, which is formed the portocaval anastomosis. No any big vessels we don't have, but we have the ligament, which is come to the liver with small veins inside of it. To avoid the damage of them, we cut not from mid and not from right, but from the left side. Remember about it, that is not hard. Now what will be consequence of your cutted layers? Skin, fat, superficial fascia, then you will see white line. Under of the white line, you will see the transverse fascia, Langenbeck space, parietal layer of the peritoneum. This is the all layers which you cut it. What is the main benefit of this incision? A little bit anatomy. You remember your peritoneal cavity is divided by transverse colon into supracolic and infracolic compartment. And you can understand that only this incision can open both compartments together. All another directions, for example, transverse, oblique, combined, will not open both these compartments because single incision, which can pass from up to down, is longitudinal. Let's say this is the main benefit of this incision. If you make whole cavity, for example, revision. For example, imagine that your patient has diffuse peritonitis. What is it? What is the diffuse peritonitis?
It is the pus
inside the whole cavity. By the way, we will study together then inside of the peritoneal cavity there are huge amount of spaces, pockets, cavities, spaces, and each one it is potential accumulational place for the pus. And if I need to have some successful treatment, I will recognize all these places, I will clean, wash all these places, and if it is necessary, of course, drain. But sorry, I cannot do it by small incision because cavity even much more bigger, and we studied previous time, than the wall. Cavity is much more bigger than the wall. So how from small incision I can, for example, make the revision of all the cavity? So I need a big one. You can ask me, but sir, it is not good because it is violated the structure. Yeah, it is violated. But then I speak about save of the life. I don't so much speak about the postoperative hernias. Yeah, I can have hernia here. Why I can have hernia here? Because I see movement, but I don't listen the voice. What is weak place?
Means like absence of
Any scar it is weak place, but why especially this midline laparotomy can give formation of hernias?
no layers, some layers.
No layers.
No.
Because you make this weakening of natural weak place. Because naturally white line, it is weak place. And if you cut it, you make it much more weaker. And weakening of weak place, it is equal to hernias or high possibility of the hernia. Do you understand me or not? So remember, please, chance of formation of hernias will be high, but again I say you, this is emergency type of incision. We do it for life-saving surgeries, not for beauty. Another longitudinal incisions presented in this picture. Look, 4, 5, and 6. 4-1 we call the paramedian, 5-1 we call transrectal, and 6-1 we call pararectal. How you should remember it? It's very easy, guys. Look. 4th-1 paramedian, it is 2 centimeters laterally to midline. 5th-1 transrectal, it is from midpoint of the width of the rectus muscle. 6th-1 pararectal, it is 2 centimeters now medially to lateral margin. There's a paramedial lateral to medial margin, pararectal vice versa, medial to the lateral margin. Do you understand me or not? Now let's understand first of all the benefit of this surgery. You understand that these kind of incisions can be performed or above or below the umbilicus. We cannot do it totally. Why we cannot do it totally? Because inside of the rectus muscle, we have intercostal neurovascular bundles. If we will make long incisions, we will damage them. And it will give, of course, the dystrophy of anterior wall with huge amount of the problems. So usually this incision is 10 centimeters long, yeah, between 2 neurovascular bundles. I want to remind you that in your anterior wall, there are 6 inferior intercostal neurovasculars from 7 up to 12. By the way, 7, 8, 9 above, 10, 11, 11, 12 below the level of umbilicus. Okay, now what is the consequence of the cutted layers? Let's start it from paramedian. Again, you cut skin, fat, superficial fascia. You come to the sheet of the rectus, because this will be not midline, but will be a little bit lateral. Now imagine that we, together, it is capsule of the rectus. I am anterior wall, she is posterior wall. And this exercise book between us, it is the rectus muscle. So you cut longitudinally anterior wall, then you apply the hook in the rectus muscle and push it to the lateral side. You don't cut the rectus. Then you cut posterior wall and consequently transverse fascia, Langenbeck, parietal pectoral. Now what will be happen after the surgery in the time of the reparation? Rectus will be between the scars and rectus will not be damaged and rectus will make great protection of anterior wall against of any hernias. Do you understand or not? I don't have total violation of structures. Between anterior cutted and posterior cutted sheets, we have non-damaged rectus muscle. Of course, you understand that this incision primary local, and it is great for local because you make the planned surgery, it is not emergency. And of course, for you, it's very important the formation of post-surgical complications, like the hernias, and you do your best to prevent. And you will prevent because anterior wall will not be weaker You save the main protectoral structure, it is rectus muscle. You don't damage it. What we are doing in case of transrectal, then you go along the midpoint of the rectus. Here again, you open the anterior wall, you come to the rectus one, but you don't cut it, you split the fibers. Yeah, we apply two, for example, dissecting forceps and bluntly split the muscular fibers from each other. By the way, for the muscles, this is the most preferable technique of the work. Not the cutting, but the splitting. Why, friends? Because then you split the muscle. First of all, you minimally damage the muscular fibers. Minimally. Secondary, you don't cut the vessels and nerves, which is inside of the muscle. Even if you will have vessels here, they will not be damaged. You will see these vessels, yeah, between the splitting margin of the muscle. But again, unfortunately, main disadvantage of this incision, it is size of it. It cannot be long. You know why? Because you will be between intersection tendons. And idea to enlarge incision by cutting of intersection tendons is very bad. Because inside of these intersection tendons, immediately we have intercostal neurovascular bundles. And if you will damage them, whole muscle will lose the supplement, which is very, very bad. Let's speak about last, sixth one, yeah? Pararectal. You know, idea approximately same to paramedian. Again, you cut the anterior wall. Now muscle is pushed to the medial side, not to the lateral side. Then you cut posterior wall and go deeper. But if I will compare possible complications for fourth and sixth, for this paramedial, sixth it is pararectal, I will see that they will be different. And you know, one will give much more hard complications comparable with another. Tell me please, in your opinion, from these two incisions, which one can give more hard complications, paramedian or pararectal?
Pararectal.
Why?
Because we have Spiegel's Spiegel's line is closer.
No, okay, it is close, but it is not in place of your incision. Your incision located much more medially to the Spiegel line. And it is longitudinal incision. It is cut immediately what is located in this level. If it is here, how it can damage something which is here? How it possible? Use your fantasy, guys. Incision is here, Spiegel is here. How this incision can damage that structure if it is longitudinal? Everything is much more simple, guys.
Aponeurosis.
So,
It is not the medially to the lateral margin of the rectal muscle. It is aponeurosis.
again, but sorry, in paramedian one also we cut this aponeurosis. What the difference in that case? Everything is simple. Look to my fingers. The more laterally you damage the intercostal vessels, the more bigger trunks will be closed. Vice versa, more medially will be your incision, the more terminal only branches you will damage. You just have very bad memory, guys. Absolutely same I teach you than we study head region. If you remember, I told you that the more inferior will be your incision, the more bigger trunk of the ascending vessels will be damaged. Because in head region, we have ascending vessels. Here we have the vessels which is passed from lateral to the medial. They say the more laterally will be your possible violation, possible, because normally you will not damage them. But possibly, incidentally, they can be damaged. And this incidence of pararectal complication will be much more dangerous than the incidence of paramedian complication. This is about longitudinal. Second group, it is the transverse. Now look, transverse incisions can be performed or in above umbilical region or in below umbilical region. Above umbilical, usually from midpoint of distance between xiphoid and umbilicus. Below umbilicus, midpoint of distance between symphysis and umbilicus. I think it's not that hard. But what the problem? What is the main problem of this incision? Incision is great. Incision is beautiful. Incision usually doesn't give formation of the hernias. Tell me why. Because it is parallel to the intercostal neurovascular bundles. They say you don't damage them usually. You locate it between them. But unfortunately, it has one big disadvantage, even two. First one, it is open only one compartment. or supracolic or infracolic. It doesn't open completely or peritoneal cavity. So if you need to make total revision by transverse incision, it will be impossible. Second problem of this incision, it needs a long time because a lot of structures you will cut it during the transverse. If previously we work along of one muscle, rectus, here you will violate it and rectus and oblique muscles together. You understand it or no? Of course, the time to cut more layers is more. The more layers you cut it, the more time you need, for example, to ligate it the vessels, and vice versa. Transverse incisions usually is one-sided, right or left to the midline, because then you make total, you make the completely weakness of the rectus muscle, which is very bad. Because you know the rectus, it is antagonist to the oblique muscles, and it is prevent the dilatation of the linea alba abdominis. Next, the group of incisions we call oblique. Oblique incisions, guys, usually located below upper or above the lower margins, borders of the anterior wall. Below upper, it can be right-sided oblique. You can see it here, or left-sided, number 2, yeah? Right-sided, we call Kocher incision. Usually we achieve the liver, gallbladder, bile ducts. Left-sided, you use to make, for example, splenectomy. Inferiorly, in right side, you will reach the cecum, appendix. In the left side, you will reach the sigma, rectum. So according to what do you make. But until now, I described for you 3 types of incisions. Yeah, longitudinal, transversal. All of them, guys, remember this. All of them open, first of all, peritoneal cavity. So we call them laparotomic incision. For example, this incision is also oblique. But it is not the laparotomic. Why? Because that's used to open the wall structures. It is the inguinal channel. This is incision to repair inguinal hernia. It is oblique by its technique, but it's not laparotomic because laparos, it is the cavity. We must open the cavity, but this one doesn't open the cavity. But oblique incisions, of course, we can use like access to the inguinal channels. They will not open the cavity, but they will be oblique. More of these 3 group of incisions which I teach you till now, guys, all of them cut the layers of the wall in one choose direction. All layers mean or longitudinally, or transversely, or obliquely. You don't change direction of cutting tissues. You start from one direction and you finish by same one. What does it mean combined incision? Here you can see big black line, yeah? Combination of 2 from previously 3 mentioned. For example, longitudinal with transverse, oblique with longitudinal, oblique with transverse. That's it. You make combination. Otherwise, instead of a line-shaped gate, you open flap-shaped gate into the peritoneal cavity. You can ask me, what is the benefit of it? Wide aperture. You know, window is bigger than, for example, some fissura in the wall. And the light can more easily come to your room. Now here we need not to provide light, we need to open and make some access. The flappy form gives us much more space for the surgery. But unfortunately, in the same time, it is much more traumatical. And it's made much more weakness of the anterior wall due to the chance of the damage of the vessels and nerves. So you can ask me, if it's so, when we will use, then we will prefer. We use such kind of incision, guys, primary if the normal anatomy is changed. If there are something which is violated, you cannot recognize the structures from narrow line-shaped incision. For example, there are huge tumor with metastases. And line shape, you can say, but sir, we can take the hooks and try to enlarge. How much? How much? Any enlargement have the borders. After this, you will just rupture the structures, which will be very bad. Is it understandable for you? But now, let's say this is the fourth type of incision, which is called combined. For example, sorry, I told you before that oblique incision in the right upper portion is called Kocher incision. I use, for example, for cholecystectomy. That is the surgery to remove the gallbladder. If there are, for example, stones, which is make some bile, for example, passage obstruction. We call it choledocholithiasis. And surgery is very complicated. We can have a lot of... But now imagine that gallbladder is perforated. And instead of simple cholecystitis, we have the bile peritonitis. Of course, Kocher will not be enough. And I will make here much more this, for example, upper middle laparotomy, which is continuous obliquely into our region, and in flap form, widely open the anterior wall. To recognize the structures, to clean them, to wash them. Or, for example, there are abscess, pus, in the region of the gallbladder. Normal anatomy of hepatoduodenal ligament, you remember, which is contained portal triad. DVA, ductus choledochlus, vena porta, arteria hepatica propria, it is changed. And I can damage these structures if from line-shaped incision, I will try to work into them, yeah, because the anatomy is changed by the pus. We have dense threads, we have shrinkings, anything else. Okay, now let's come to the last group, fifth group of incisions, which we call changing. What does it mean, changing? And what is the principal difference between this incision with four previously mentioned? Well, simply, guys, direction of different layers incisions is change. We don't start and finish in one direction. And, yeah, please. And primary, guys, we change this direction in the level of the muscles. Because as I say you before, we prefer not to cut the muscles, but we prefer to split the muscles. It is much more safe for the muscular tissue. Examples I give for you, for example, Pfannenstiel, which we call for scissor section, or McBurney blue incision, which you see for appendectomy. So for McBurney incision, I think you know, yeah, or if you don't know, we will study in the future. I will introduce only the type of incision, not the technique of surgery, of course. How we make it. First of all, as you can see, we really draw imaginary line. And this imaginary line connected right anterior superior iliac spine with umbilicus. Then we divided this imaginary line into three parts. And the point which is located between lateral and mid-third, we call McBurney point. Once again, in the imaginary line, we find the border between lateral and mid-third. We call it McBurney point. By the way, that is the point of projection of the pins from the appendix. So maximal painful place in the wall will be the McBurney point. And from McBurney point, we make incision. Blue line, now it is real incision. And this incision is perpendicular to our imaginary line. And 1/3 of this incision located above perpendicular line, 2/3 of incision located below perpendicular line. Length of this incision for adults approximately 7-8 centimeters. That is direction of your skin incision, not direction of complete incision. In this direction, by the way, it is oblique, yeah, as you can see. You cut skin, fat, superficial tissue, and finally, aponeurosis of external oblique. Immediately under of it, you see muscles. It is internal oblique and transverse. Now, direction of your incision is changed. Instead of the direction which I show, you go belong the muscular fibers. And you split it primary, firstly internal, then secondary transverse abdominal. All another layers, you cut it in same blue direction. I mean the transverse fascia, Langenbeck space, and parietal layer of peritoneum. You can say me, sir, why we need to make this complication? What does it give for us? Because this is really complication. Instead to cut everything in one direction, you change the incisional form, you waste the time. You waste the time because it's much more easy to cut everything in one direction. But what we achieve? What we achieve?
We preserve the structure of the muscle instead of just bluntly cutting.
First of all, we preserve the muscle and we preserve the function of the muscle. What else? What else?
Neurovascular bundles between the
Neurovascular bundles can be damaged anyhow. You will try to do your best to not do it, but you can, because this is not incision which is parallel to them. It's very simple. You prevent formation of the hernias. You know why? Now imagine that me and our friend, it is 2 layers, and you cut both of us in one direction. Finally, along of all this direction, we will have total scar, because we will be fused to each other, and connective tissue will be formed. But now imagine that I am cut it, for example, transversely, she is cut it longitudinally, something like this. In that case, total scar I will have only in cross point of these 2 incisions. Along of all another place, under the superficial, I will have the normal tissue. Or in front of the cutted, I will have the normal non-cutted. Instead of the total scar, I will have pointed scar. But pointed scar is much more shorter and smaller. There's a chance of formation of the hernias will be reduced. Is it understandable? Pfannenstein also example of the changing. You know we can make delivery by the Pfannenstein. Yeah, we cut the uterus. How we cut the skin? 5 centimeter, 4 centimeter above the pubic symphysis, we have the skin fold, and we make the horseshoe shape incision along the skin fold. Why skin fold is preferable? Cosmetologically, it's better, guys. Scar will be invisible. You cut all layers up to the rectus sheath and white line in this transverse direction. By the way, incision started from lateral margin of one rectus and goes to the lateral margin of another rectus. Then you see white line, and you make classical inferior midline incision between rectus right and left. And you separated rectuses from each other by the hook. All another layers also, you cut it longitudinally up to the uterus. Then you make section of the uterus and then you remove the child from it. So changing, why it's changing? Because you change direction of incision. From transverse you goes to the longitudinal. Do you understand it or no? Super. Now let's come to our main topic, which I want to introduce you now. That is the topic about the inguinal hernia repair surgery. Look to me, guys, look everybody. Nowadays we call it not the herniotomy, even not herniectomy. By the way, in old times this surgery is called herniotomy. You know why? Because of course they doesn't make the scientific surgical access. They have just one sharp instrument, which is sharp from 2 sides, and which is called herniatome. Like the knife, but narrow. They inserted this herniatome inside of the ring and try to cut one side of the ring, usually external ring, yeah, to reduce the strangulation. They say only if the person will be died by hernia, you know that the ring can press content. They try very, very politely to cut this ring without damaging of content, yeah, because if the content will be damaged, the person will be dead. Unfortunately, huge amount of the complications, a lot of people die, but sometimes it gives them the positive results. Of course, much more usually positive result will be if the hernia will be obstructed inside of superficial ring, because superficial ring can be simply achieved under the skin. But if it is compression inside of deep ring, which is much more usual, because I say you, the size of deep ring is smaller than the size of superficial. By the way, inside of deep ring will be pressed the indirect hernia, because it is passed through the deep ring. Inside of superficial ring, we can have the pressure of direct hernia, but incidence is less, because superficial ring is bigger. More of this, dear. Who can say me why direct hernia have more chance to be pressed inside of the rings? Who will answer? Immediately I will put the 10. 100% logical question. I say first cause. Why indirect one much more usually is pressed? Because deep ring is smaller. Who will tell me second cause? Why indirect hernia more usually can be strangulated than direct? I will put immediately 10.
Spermatic cord.
By the way, even you can mention not one, but two causes why it can be more easily strangulated, except the size of the deep ring. It's so simple. You just need to study the subject. You even don't need any logics. Cause number one, because usually indirect hernia is bigger. I told you that in front of it we don't have transverse fascia. So it can be protruded more. Let's say the more will be the size of the protrusion, the more easy it can be compressed inside of ring. Yeah? But there are a third reason why it can be more simply compressed. Who will say I will put 10? No, you have big problem with the gray matter. Huge problem. No? 9 idea. No. No. You need Google in help to write and that you answer. ChatGPT. Yeah. You will forget after several times, guys, to make your own decisions. This is the biggest problem which we can have in the future. Without your cell phones, you will not make any decision. Without the artificial intelligence is great, but natural one is little bit better. Don't lose your natural intelligence. Otherwise, guys, you will be, like the small appendix to the artificial intelligence. It's so simple, guys. Something which is passed from two rings have much more chance to be pressed than the structure which is passed only through one. You know what the problem? Indirect hernia possibly pass through the two rings. It is started from deep and it is continuous up to superficial. Direct one doesn't have any tension to the deep ring. It is passed only through the superficial. So guys, it is so easy. It is so easy. I told you 100 times, if or until, let's use this, until your subject will not be interesting for you, until you will not understand for what you study, your educational process will be unsuccessful and very boring. Guys, that is not my fantasy. That is my experience. You study for mark. You don't come to conclusion that knowledge little bit differ from mark. That knowledge is necessary for the future creation. Let's continue. Let's say, why we call, okay, you can say herniatomy we don't call because we don't cut anything. We remove the hernia. But can I say that nowadays surgery in case of inguinal hernias can be called just herniectomy? Ectomy, it means find the hernia and remove it. Is it correct to call the surgery not hernia repair, but herniectomy? And why it is not correct? No, we remove the content. We reduce it, push it inside of the peritoneal cavity, we remove the sac. That is ectomy. Means I remove the hernia. I really remove the hernia. Of course, you can say I don't cut the content. I don't need to cut it. I push it back. And I cut the sac and remove it. This is ectomy. But why surgery should be called repair of the hernia, not the ectomy? I answered in 90% of my own question. Sorry? But we remove the sac. That's why this is ectomy. Again, I tell you. Once again, And
So one hernia is one coming.
and what I should do except removing of hernia?
Repairing the
Super, your name.
Gopika.
Gopika. If you are so clever person, Gopika, why you don't study every time? 10. Super answer. Today it is single person who answering such a simple question. Okay, I remove the hernia. Is it my benefit? After 2 days I will see the new one. Let's say this surgery has 2 steps. First is remove the hernia. Second, make the plastical reconstruction of this weak place. Do you understand or no? Majority of you even don't understand what about I speak, friend. You don't understand. You work in the weakness of the weak place. Okay, one protrusion you remove. Who will make the insurance that after 2 days the new protrusion will not be happen? Because you make more violation. You see, it is weakness in stage 3 now. First of all, there are natural weak places. Gods know why it become to the more weaker and hernia is originated. Now we are much more make incision in this weakness of the weak place and make the next stage of the weakening. So if I will just remove this hernia, we'll make herniaectomy. After several days, I will achieve the new one. And I will continue and then continue my herniaectomy surgeries until what? As I remember, please, technique of this surgery divided into 2 stages. That's why it's called hernia repair surgery, not ectomy. First stage, it is really ectomy. I find the hernia, I push back the content, and I ectomy the sac. This is a completely herniaectomy. But second one, as she said, I must to make the reconstruction of this place, to make it stronger, and to prevent formation of the hernias in the future. That's why please, in the future, call this surgery hernia repair surgery, not herniaectomy surgery. As any surgery, it has 3 stages. Stage 1, access. Stage 2, technique. Stage 3, suturing. As I say, you technique divided in its turn into 2 stages. Finding and removing of the hernia, we call it ectomy, and reconstruction. But let's start from the surgical incision. You can see that the black line, by its form, it is oblique. It cannot be called laparotomy because it doesn't open the cavity, it is open the wall. Very dislocated. You can see that it's located along inguinal ligament and approximately 2 centimeters above it, because channel located above the ligament. But look, guys, if you will read the text, it is written along of all inguinal ligament. But that is small mistake. You make incision not along of all inguinal ligament, but along of inferior 2/3 of it. Who can tell me why?
Because the inferior free margin of the transverse abdominis.
Maybe shorter you will try to
Inguinal
see.
channel is present.
Because in upper third, we don't have any channel. If I need to open channel, I must make incision along inferior 2/3. Because as you remember, 1 centimeter above and laterally to the midline of inguinal ligament, we have deep ring of inguinal channel. That is start of the channel. In the finish of the inguinal ligament, we have superficial ring. That is the finish of your channel. So it is very logical that I will make necessary violation, not more than necessary. Necessary violation will open the channel, nothing more. Now I have second question with the gift. With the gift, why I open whole channel if it is direct hernia? I know that direct hernia doesn't locate it in whole channel. It is located only in superficial ring. Hey, you don't even understand. Yeah, my dear small child, you don't understand what I do. Repeat, please.
Why we don't open the whole channel? If
Vice versa. Why we open the whole channel? Continue. What is my question?
Why we open the whole channel if it is indirect?
No, dear.
Direct.
No, dear. Once again, repeat my single sentence which I give you.
Why we don't? Why we open the whole channel if it is indirect?
No, dear. You see, You're a small child, friend. You're like in forest. It is black forest, and you're small child, and you're confused here. You don't know by which direction you can achieve your home. That is all. Even you're a good student, I know you are not bad student. But friends, why you are in show of the children's? I don't know. Why you take the role of the children's? I can say why she is in this position, because she didn't study my previous lesson. If she will study, she will know that direct hernia doesn't locate it inside of channel. Direct hernia located in superficial ring of the channel. So God's know why I open whole channel in case of direct hernia. That is my question. Listen, why I open all channel if the person has direct hernia? Because why I open whole channel if there are indirect? It is logically understandable. Because indirect hernia located inside of channel. That's why I open whole channel. But God's know why I open the channel also in case of, because I say for all hernias, this is the same incision. Despite, is it the direct or indirect? Even despite, is it congenital or acquired? Because in congenital and acquired, both is indirect and both is inside of channel. Now, who can answer in my question? If my patient, this is patient, I know that he or she have the direct hernia, why I should open all the channel? She answered 2 minutes before. You are so non-attentive, friends. She said 2 minutes before, she said, sir, it is not enough to find the hernia. She said, it's not enough to remove this hernia. You must reconstruct it, this channel, because this channel is weak. Because if you will not reconstruct it, this channel, after I will achieve indirect and indirect and another forms. Even after the answer, 3 minutes after, you cannot just repeat it. Now you understand why whole channel I open, even in case if the hernia doesn't locate it in it. You understand or not? Because I need to reconstruct the weak place. What is the name of the weak place? What is the name?
Inguinal channel.
No.
Deep rings.
No. Inguinal space is name of this weak place. And it is much more weaker in place of fossa medialis and lateralis, because here one more layers is absent. As you remember, generally all space lack two muscles, internal oblique and transverse. In place of fossa lateralis also we don't have transverse fascia, because the deep ring, it is the deficit of the transverse. In case of fossa medialis, we don't have the anterior wall, external oblique aponeurosis, because the aperture, it is located here. So my weak place, it is inguinal space. I must make it stronger. Do you understand me? By this direction, I cut skin, fatty tissue, 2 layers of superficial fascia. By the way, here I will see arteria epigastrica superficialis, which is in fat, and I must do ligate and cut it. And finally, white structure in the left side. It is aponeurosis of external oblique. You can see using the groove probe. Do you see the groove probe? Yeah, friend, do you see the groove probe or
Yes,
not?
yes, sir.
Are you sure? Go to the picture and show it, please. I will see now. What do you see? Where is the groove probe? Go. Friend, do you know where is the Hollywood? Try yourself in, or in Bollywood, I don't know. You choose the Hollywood or Bollywood, I don't know. You're a great showman. Great. This is the groove probe here.
Yes, that's what I pointed at the end.
So it's not necessary to show the last point, it's necessary to show the instrument. Why you need to show last point if there are huge body here?
No, sir. Over there it was easily.
Okay. Don't worry, after 3 minutes I will ask you another question. Don't worry. You will prove myself that you are correct. You know why we use the groove probe? To not damage the deeper located structure. What is deeper located? Of course, the spermatic cord. Let's say I make small aperture, I inserted the groove probe, and along the groove probe I cut the external oblique. And what I find finally, this picture. This is inguinal channel, and inside of inguinal channel I see, what is it? What is it?
Spermatic cord.
You are much more better to not answer, yeah?
Cord.
Spermatic cord, of course. Spermatic cord, of course. Because if it is direct hernia, it will be not inside of this channel, it will be here. If it is indirect hernia,
Channel. Inside of the channel. Inguinal channel.
that's enough.
Which one?
That's enough. It is just inside of channel. It is just inside of channel. Of course, thank you very much. Again, I will not find the hernia after of the opening of the channel, even the indirect one. Why? Because it will not be just in the channel. It will be inside of spermatic cord. And how I can make it visible? Surgeons show how. I will split it, the membranes which is covered the spermatic cord, 3 membranes. Fascia cremasterica, musculus cremaster, fascia spermatic. Only after this, I will see elements of the spermatic cord, and between these elements, I will see the sac. By the way, in majority of the cases, sac will be empty. Why it will be empty? First of all, because majority of the hernias is reducible. And secondary, then you use the general anesthesia, you injected the myorelaxants. That is the medicines which is decrease the pressure inside of the peritoneum. Why? To prevent the eventration of intestine. Then you decrease the pressure, reducible hernia go back. Say, again I say you can find or sac with content or empty sac. Both situations is possible. But anyhow, you will recognize it. Why? Because it is transparent, shining, then the light is touched to it. And peritoneum, yeah, you know what is the peritoneum. Now what after? After my access is finished. Access is finished, and I will start to make technique. I make access. And now I will start to make technique. First stage of my technique, it is herniaectomy. I should remove the hernia. What I will do, first of all, you see, I separated my sac from all neighboring structures. They can be connected to each other due to the small inflammation. Bluntly, I separated the sac from the neighboring structures. Finally, I must to see complete sac. When I say complete sac, guys, I imagine 3 parts of it. That is the ring, yeah? That is the ring. Complete sac has number 1, number 2, and number 3 compartments. How we call them?
Sac and content. Ring, sac and content.
There is the ring, friend. This is the ring.
Neck.
This is the ring.
Neck.
Of course, neck, body, leg. Fundus, of course. This is fundus, this is body, this is neck. It's like I will completely separate it, the sac from any other structures, yeah? And what will be our ring? What will be our ring?
So really.
Pasat
How do you want it?
Jest to całe.
I showed him the probe exactly what it was. He won't ask him. I showed him.